Congratulations, Karen.
Well, thank you.
Good afternoon, everyone. Hi, my name is Dawn Bose. I'm with GSI Health, and I'm going to be here to introduce the panelists. Before I do, I just wanted to quickly introduce GSI Health. GSI Health provides care coordination software across the continuum of care for the whole patient. So with that, the next panelist is the ACO and Patient Engagement Panel. And on the panel is Lynn Barr, who's the Director of Rural ACOs, Thomas Mulhern, who's the Senior Vice President, Chief Innovation Officer of Datu Health, and Karen Tejcka, who's the Area Chief Administrative Officer at Kaiser Permanente. And the moderator for the panel today will be Jan Oldenburg, who's the principal of Jan Oldenburg Consulting. Jan is a nationally recognized thought leader on consumer health information strategy and patient engagement. She consults to organizations on topics related to patient-provider engagement and activation with a focus on digital health technology. Prior to her current role as a principal in her own consulting company, she was the vice president of patient and provider engagement in accountable care solutions from Aetna, where she helped build patient-provider engagement programs for accountable care organizations. So with that, I'd like to introduce Jan Oldenburg.
Welcome. So glad to be up here, and it's clear that between everybody who has spoken before us, thank you. Yeah. You probably can't see me over this either, can you? I'll stand to the side. But then I create that problem. Anyway, we have certainly laid the groundwork effectively for this panel with the earlier conversations. We are talking to you about innovating and collaborating to improve population health around specifically patient engagement and ACOs. And the premise for this is that if we don't figure out how to get patient engagement right, we're not going to figure out how to get the move from fee-for-service to fee-for-value medicine right. So this is a critical piece of really going to the next generation of healthcare capabilities. And I think that we're going to reflect a number of different points of view that should be enlightening and engaging, but what we really want this panel to do is respond to audience questions. We've got a bunch of canned questions that we can ask, but we're hoping that we are brief and succinct in our initial presentations and that it'll spur a lot of discussion and debate across the audience. So remember that, help us keep on track. We're each going to take no more than 5-ish minutes to go through our stuff so that we can get to the discussion. I'm going to start by defining patient engagement because I think it's important if we're having this conversation that we have a shared definition. This is a definition that is actually sourced by the Center for Advancing Health, and they have defined it as actions individuals must take to get the greatest benefit from the healthcare services available to them. And I really like it because they go on to specifically say that engagement is not synonymous with compliance. And I think this is one of our errors in the healthcare system. For years, we have defined the best patient as a compliant patient. And then we turn around and complain that patients aren't taking actions about their own health. Well, guess what? We've taught them learned helplessness. So as we move forward, we really need to think about engagement, not as having them do the stuff that's reasonable for us, that we want them to do, as the questioner over here asked, but we have to make sure that we're thinking about what do they need in the lives that they're living, in the situations that they're in, and how can we support them in that. That's the community part of engagement. That's the family part of engagement. That's part of being partners with our patients in creating healthier communities. We also know that everybody comes to us at different stages of engagement, and we can't have a one-size-fits-all strategy for it. So personalized medicine really is a key part of engaging patients in their own care. And we have to figure out, as they're already working on with the PAM scores, what's different in the way that we need to talk to people and approach people who are resistant to any conversation about their health or their smoking habits, who really don't want to be in our offices, versus how do we have a conversation with somebody who's a self-tracker, who is on top of their disease, who may know more than we do about the impact of the drugs they're taking or the situation that they're in. And that's a piece of this, which is figuring out how to have different conversations, different tools, different metrics based on where people are in their lives and in their engagement framework. To do this, we got to get a lot of this new stuff right and start incorporating it. Patient engagement might be the definition of the place that disruptive medicine is going to come to the fore. So we're hoping to have all of that wrapped into this conversation. And I just want to note, if you're interested, I've arranged for a discount for this group on the Engage book, either the digital version or the in-print version. You can buy it at HIMSS Media. The links are on here. And with this discount code, Engage 2014 SC, you can get a 20% discount through the ad. Sorry about the ad. Lynn Barr, you are up next.
Well, hi, everybody. Thank you very much for having me here today. We can get that off the screen pretty quickly. Oh, and there's, can you click on that? You can go back.
See if I can help. I'm sorry, I didn't have a chance to make sure that it would work.
Keep going.
But we'll see if it.
Yes, that's
Let
going to
me
work.
see if I can get it going.
We're trying multimedia today. We'll see if that works.
Multimedia and distance.
We will find out. At any rate, it's a pleasure to be here today. While they're getting that up, I'll tell you a little bit about what we're doing. I'm the founder of the National Rural ACO, and so the topics you're talking about today about community and about patient engagement are really very, very central to the work that we're trying to do. Rural health has evolved over time to become mini Kaisers, little integrated delivery networks, where the critical access hospitals or the rural hospitals have slowly but surely integrated with every piece of healthcare in their community. And these rural health systems actually provide 70% of the services that most people enjoy or need in their lifetime. So the approach that we're taking with the National Rural ACO is to try to create a situation, and we'll find out, I think this is about to start, where we can bring the community together around the patient.
This hospital was formed by the community in 1932. The mission is exactly the same as it was when we were founded. It's to improve the health of the community. In Batesville, Indiana, we're very lucky. In this region, we have strong manufacturing. We have companies wanting to come in here. I know they would not be doing that. They would not be expanding their facilities or looking at this area if it wasn't for a vibrant healthcare system.
So ACO, Accountable Care Organization, is a way for us to start thinking about the health of a community and how the finances might support improving the health of a community.
I feel, and the leadership at this organization feels, that the fee-for-service model that we're under right now is not going to last long. When you talk to policymakers in Washington, when you talk to Republicans and Democrats alike, they feel we're paying too much for health care as it is, and the system is not efficient in how it delivers health care.
If you look at the cost of health care, the only way to really impact it now is to try to prevent diseases and reduce admissions and reduce hospitalizations. And overall, if you keep people healthier, they won't utilize the healthcare system in the ways that they have in the past.
Instead of waiting for people to become ill and then we bring them into the hospital and get them better, we try to back that up a little bit and say, all right, what can we do to prevent this heart disease, or what we can do to keep your diabetes under control? So it's sort of transitioning the way we think now to thinking outside of that hospital box.
23% of Medicare fee-for-service beneficiaries live in rural communities. So we're about a quarter of the Medicare budget. That's a big number, but they don't know what to do with us. They don't really understand how to pay for us. But I think that with this movement, we can change that.
The country is going in a different direction, and that we're going to have to respond to that. I'm always been a believer that we have to be part of the change and not wait for the change to happen and then try to respond.
Yeah, I mean, they always say change is inevitable, but growth is optional, and I look at this as an opportunity for us to grow. And you're either, I don't think anyone stays status quo. You're either improving or you're not improving. So I think by going with the ACO route, we're going to be improving, we're going to be improving the outcomes, and we're going to be improving patient care in the community.
The issues in rural America are quite different than they are in urban America. And so we've got to have systems of care that really do much better for population health and for providing all these services and allow rural hospitals to be sustainable. So I think that's what the Accountable Care Organization can do, and particularly the National Rural Accountable Care Organization can really facilitate sustainable systems in rural communities.
So we've started a movement out in rural, and what was really surprising to us is as we began this program, how many people really wanted to do this. So these little rural health systems are all about the community. Now, most of them are taxpayer supported, and they have special district taxes. They're very small, they're very fragile. And when we went out last year and said, it occurred to us that the government was not going to solve our problems, and we were going to have to figure it out, and that the only way we could become an ACO is if we started try to bring all of rural together into one big ACO, because we didn't have the money and we didn't have the beneficiaries. And we sent out an email to our friends and family across the country, and these little blue dots were the people that shot us a letter of intent within like 30 days. And then the red guys, they actually had 60 days to convince their boards to jump off this cliff with us and do this crazy thing. And so the red dots were the ones that got through that process, and there were 9 of them that started the ACO this year. What's kind of exciting right now is that was the pilot ACO, and we're in the process of putting together our applications for the 2015 cycle, where we have, at last count, 82 communities and 15 ACOs that we're going to be submitting to CMS for 2015, and 2016 probably looks like 250. So community health systems are getting this. They like the idea that we are going to get paid for keeping people healthy, and that our strength in rural communities is relationships, and that we have become convinced that by establishing a relationship with that patient, we can win this. When we look at the patients that we're focusing on, the money ball, right, that 10% of the patients that are 60% of the healthcare spend in our community, well, for us, we're talking about a couple hundred people, right? A couple hundred people. I can hire one care coordinator for an entire community, and I can save millions of dollars. Isn't that amazing? So the question that I have for you is, along the lines of patient engagement, is how do you help me reach that 10%? And knowing that 100% of them, or close to 100% of them, have behavioral and mental health comorbidities. What type of patient engagement tools can solve that? Because that's what I have to solve. It's not another drug, it's not another pill. It's really solving the pain in that person's soul. And that's what we're here to talk about today. So what is patient engagement for us? And why engage the patient? So for us, again, it's really about, why do you do it? Obviously you want them to manage their disease and to improve their outcomes. But the goal of patient engagement in a rural community, and I think in many communities, is to build a relationship. So it's not about managing a disease. It's about creating a tie between two people, that when I get up and I want to have that cheeseburger, I think about my care coordinator and what she would say about that, and I think differently. Thank you.
You're up next.
Thank you. Quick minute.
Thank you for inviting me today. It's a great pleasure. I thank Jim Brady for asking me to come today. I've lost my voice a little, so I apologize. I'm going to talk just very briefly today about a little bit about the what. We've talked about the why quite a bit today. And I think that for purposes of today, I'm going to bring it down to a little more micro level of what the patient sees every day, or the member actually sees in our organization. I'm the Chief Administrative Officer for Orange County. There are 3 leaders in Orange County. There's a physician leader, there's a hospital health plan leader, and then there's the ambulatory care leader, and I'm that individual. Together, we manage to provide high quality health care for all of the members that we serve. So briefly, who is Kaiser Permanente? I know you've heard a lot about us, but just to bring it down a little bit closer, we serve about 9 million members across the country. In Southern California alone, we serve 3.5 million of those members. And in Orange County, where I work, we have about 470,000 members and growing every day. We are a nonprofit organization, interestingly enough. So everything is plowed back into operations, building medical office buildings, building new hospitals, building computer infrastructure and the like. We spend about $2 billion a year in supporting community health in a wide variety of ways. This includes everything from establishing and supporting food banks, to promoting healthy lifestyles in underserved communities, supporting community clinics, and I could go on and on about that, even summer swimming clinics here in the LA area. Our capital plan really reflects the fact that we have to grow and operate efficiently and effectively because we are probably the largest prepaid health plan in America today. We're one of the largest primary care medical home organizations in America today, and we've really been operating that way for almost 70 years. We have 38 hospitals in America. We have 175,000 employees. In Orange County alone, we have 7,000 employees, including our physicians. Our heritage goes back about 70 years now, and remember, we were a prepaid organization from day one. So it's always been about supporting health and supporting prevention. So all of our programs and our systems are geared in that direction, and I believe that now we're able to proudly say that we're one of the original ACOs. And if you look carefully at some of the photographs of the original signing of the ACA, you'll see George Halverson, our prior CEO, prominently at the table, because this ACA development was developed in part with Kaiser Permanente's philosophy and organization behind that framework. We have, forgot to mention, 2 hospitals, 23 clinics, and we're opening several more. So on this rate, we're opening about 1 or 2 every year, new medical office buildings. So I'm just going to talk quickly about engagement and some of the things we have. KP.org, you're all familiar with. I think we enjoy the same platform as the Navy gentleman was talking about before, our electronic medical record. And the electronic engagement with our members is probably highest and most importantly with this tool in your hand. It's the iPhone and it's the KP.org app. On that app, you can engage as a member with almost anything you regularly need. And you can get it anywhere you are. You can talk to your physician. You can reorder prescriptions. You can go online and look at patient education materials. I can find where the local pharmacy is, or better yet, have it refilled at through direct mail. And then, of course, I could actually look at my medical record and discuss some of the aspects of that medical record with my physician or my nurse practitioner. Innovations, there's a lot of those. I only listed a few of the things that I'm mostly engaged in lately around this, but I would say that along the lines of what we were hearing at the lunchtime conversation today with the keynote speaker, the data mining component is an underpinning of almost everything that we're doing around patient outcome, and I'll talk about that a little more later when we have some time around that. Telehealth is another one. Many projects around that, and I can get into specifics about that later if you'd like. Even wayfinding. If you go on Google Maps and you look up KP Walnut Creek, you go on there, you check that out. That just happens to be something in Northern California that we're bringing down very soon in Southern California. And you can actually wayfind and navigate your way around the medical office building so you get to the place that you need to be. So we're even going that far to use our digital programs. Health radio and digital member card. The point here is that we're trying to deliver health to where you are. And I don't even like to call our member a patient, because that denotes something around them being defined as patient. In my world, it's really talking about member. My focus on is providing health to you where you are, when you need it, at the time you need it. We're also redefining a lot of our target market segments, not only in terms of how we outreach, which I can get into later if you'd like, but also around the area of redefining and redesigning ambulatory care. So it's really going to look very different in the future, with a lot more telehealth and a lot less buildings along the way. So with that, I will, just as a little teaser, be happy to take questions later along the way. Thank you.
Thank you, Karen. And now we have our friend from the Datu Health.
Datu Health.
Thomas.
You should never make a tricky logo. Is this sort of more or less working? It's not at all. It's right. Yeah. Let's see.
You might have to turn it on.
No?
No, there's a switch on the back.
Well, I've got the switch and it says it's on. The question is.
Here, we're doing that.
There we go. Thanks. Okay, there you go. So Jan promised you a diversity of human beings and perspectives, oh, they kind of took my slides and did stuff with them. How exciting! We'll see. And so I am coming from a different place, really coming from a different industry to start with. I've spent most of my life in product and service innovation and in brand strategy. And part of how it came to be in the situation I'm in is a partner of mine started a business about a year ago. A former partner of mine from brand strategy days started a business a couple of years ago focused on patient engagement in healthcare, and focused really on particularly on the leverage and utilization of data in building the patient engagement and building the patient relationship. And that became Datu. It's a fusion of data and you. I think all of the things that Dr. Madison talked about this morning, and I'm sure they're not at all foreign to you, are the world that he described is going to happen sooner than any of us think. And you know, it's coming faster. It's being accelerated by companies as diverse as Nike, as Intel, which has bought Basis on this wrist. Obviously, these guys are getting into the game in a big way, and it's also being fueled by latest count, $500 million of venture capital behind things like this AliveCor heart monitor. So the data that is flowing into the personal health system, not the clinical health system. The data is flowing into the personal health system is going to be like a beach compared to a grain of sand inside of your current enterprise data warehouses, and that doesn't necessarily have to mean anything, except that in so many other parts of our lives, data about ourselves, data about who we are, whether that's our face in a mirror or our Facebook feeds, is a powerful tool to engage us in relationships. And so day two is about trying to build on that opportunity as we go forward. We began working on a contract as a consulting business with St. Joseph Health System in Orange County. And about half a year ago, day two was spun off and created as a joint venture between St. Joseph Health System and the ownership of the firm. And as part of that, we're working to build a solution at St. Joseph Health and then also take that to market for other health systems that might find that of value. And maybe ones that aren't quite as far ahead of the game as my co-panelist here. But what's intriguing to me, or what's maybe important when it comes to, so this is day 2, and we're focused on, as I said, on you know, both the clinical data from the EHR, but also the personal data from, you know, for want of a better term, from my wrist. And both the acute data and the ambulatory data, so as part of this is bringing together lots of streams of data in an HIE, and both quantitative and qualitative data. So it's all kinds of data. When I talk about data, I'm not just talking about feeds coming out of an EHR, I'm really talking about diverse sources. And all of that being applied to activate patients, as we've talked about, as other people have talked about, and to nudge patients into behaviors that are positive, to Jan's definition that she gave. And really being about not just the system of healthcare needs that the clinical health system is built for, but also the system of consumer wants. So a lot of our team comes from consumer brand opportunities where the point is to create meaning around what consumers want, not just action around what they need to do. And I think some of these things have been really well addressed by other speakers today, and I'll be happy to dive into them. I want to talk a little bit about the challenge that we were given by St. Joseph Health, because I think this is really critically important to this idea of meaning. We were challenged around mission outcomes at St. Joseph Health. So St. Joseph Health System has 3 mission outcomes defined by their mission that has existed as long as they've been in the state. And those mission outcomes are perfect care, which is not perhaps surprising, an aspiration to excellence in the care of people. Healthiest communities, which has always been a kind of a feature, I think, of many healthcare organizations. You talked about in terms of the rural communities, and I think that's always been a focus of Kaiser, is to build communities, not just build better bodies, but to build healthier communities. And the last mission outcome for St. Joseph Health, which has been our a challenge, a riddle, a puzzle, a gauntlet thrown down for us, is sacred encounters. Because in the construct of health that St. Joseph Health System has, the encounter with the physician is not simply a matter of healing the body, but it's a deeper relationship with a human being, and it's about the whole person by definition, and the whole person, not just you know, physical and financial, but also spiritual. And so our aspiration as designers, and we're not all the way off this journey right now. I'm at the very beginning of a journey, not at the 70-year point, but at the 18 months point, is we're trying to build digital encounters that can hit that bar. And a big part of it is to build dialogue and what we're calling collaborative care programs. So underneath all of this is what you might call kind of a typical medical records portal that's being built out. So it sits on top of a health, you know, an interface engine. It's connecting up to Allscripts and Meditech, pulling them together, and master patient index, and bringing forward all the data that we have about patients. But that's just sort of step 1. Step 2 is to activate that in care programs, collaborative care programs that put the same data in front of in front of the community member as in front of the clinician. In particular, this is focused around clinicians who don't already have great systems. So this is the clinicians who are not necessarily order entry system users, but clinicians like care coordinators, care managers, nurse navigators, who need to get a picture of that patient, and not just a picture of what's going on in that EHR, but also a picture of what's happening in their lives outside of it. So being able to take the self-tracking data, to be able to watch that, to be able to, as one of my colleagues says, got a very simple mantra. He says, look, it's not that hard. It's about, you've got to collect that data. You don't know, even if you don't know what it's going to be used for. I think that Dr. Madison had a great answer toward the end. As long as you know where you collected it from, you don't have to worry about whether it's perfectly accurate or not, as long as you have provenance and you know what you're looking at, and that's the system we're building. And you've got to collect it, you've got to just count it. Just to know what my steps are is powerful, can be mindfulness, motivation. You can compare it, that's his 3rd C, which is about being able to compare it to other people like me. It's being able to compare it to averages. It's being able to compare it to me last week, last month, last year, and really being able to another term I picked up from Dr. Madison this morning was the nomogram, to compare it to my sort of baseline and understand that things are relative as you come back to health. I bet I could get you to guess it. Diabetes. Since diabetes care is a serious thing, and it also has a lot of, it lends itself to a certain amount of the numeration and data gathering and know your numbers logic. But we're also gathering them around other critical life stages, and we're gathering teams that have clinical representation, have medical direction, have nurses and care navigators and care connect nurses and educators, and really looking at the nascent population health resources that are being built by the St. Joseph Health System and the Heritage Network to pull them together and connect the dots into one unified user experience. So then this is just as a final kind of like taste of what's on my mind around this. This is really about finding that data that's salient, presenting it in ways that are relevant, and then putting other information in context of that data so that people can make good decisions, so people can be led into the decision process, and so that there can be true collaboration. There are so many roadblocks in what we're doing right now, and as I listen to everybody talk today, so many roadblocks around patient engagement. For our company and for the health systems that we're working with, what we're trying to do is get them in the game so they can begin to understand those roadblocks, deal with them, and make progress toward overcoming them, because if they're not overcome, population health is just a fiction.
Can you hear me?
Did you get the bad mic?
There's a switch on that mic. Not that one. Yeah, just go ahead and put it in the on position.
Okay, now I'm sure you can hear me. Right. So thank you for those opening frameworks. I'm going to kick us off with a question, but as I said earlier, this is going to be better if it's your questions, not our questions. So please start thinking, and those of you with microphones, start being ready to assist us. But I want to ask our panelists, I think one of the things that is the single best indicator of an individual's engagement may be whether they've got a trusted relationship with someone in the healthcare system. And I'm fond of saying that you don't get engaged patients without staff, physicians, and community that's engaged. So can our panelists speak to what you're doing to facilitate relationship, and in particular, what digital tools as well as in-person tools you're using to do that?
At the National Rural ACO, the first thing we do when we launch a community is we bring in all of the community partners. So we bring the churches in, the food bank, the Rotary Club, everybody that has something to say about Obamacare, and bring them all together into a room and talk about what we're trying to do. And so what we want to do is not just engage them in the health system, but engage them in those community resources and engage the community and activate the community so that they understand that we have a goal for the community. In terms of technology, we've developed an application, a smartphone application, to a patient engagement tool for communication of the patients. But since we're really dealing with the Medicare population, that wasn't really taking off. So the next thing, we moved from that to having an iPad at the point of discharge for every patient. So one of the big challenges with Meaningful Use Stage 2, which is one of our measures, is getting rural patients to access the portal. Right, it just doesn't happen. A lot of them don't have internet, and so what we did was we created a little a 7-question iPad survey on discharge, and as part of the discharge workflow process now, they take a 7-question survey on how that experience of care was for them that day, and then we also show them, and here's where your PHR is. And so at least we get them to access it once while they're in the office. So, trying to move them towards that new state.
And I don't want to imply that we have to go down the line on everything. So pitch in, whoever wants to pitch in.
I mentioned the use of kp.org. We have about 70% of our population in Orange County signed up with kp.org. And we focus on that very actively because we know the research shows us that once our members use it, they're happier with the health plan, they're happier with their care, and they're actually achieving more goals by actually using that website. So with that said, most of this relates just on a touch basis with a member coming to our medical office building. Many of you have after-visit summaries and things like that that actually put into language what was discussed and said around their particular visit. But there's much more than that. We focus very heavily on bonding rates, and we use that and look at how often does our member actually touch the primary care provider. So all of this, again, for you who are in HIMSS, is all, again, electronically based upon information for each visit and each touch for the member, whether they actually visited us or not. Physical visit, I should say. We also look at language skills very carefully. We document language of preference, how able they are to speak in one of the two languages that that they've mentioned in their medical record. And then we look very carefully at, does our providers, does our staff reflect the local community and the local membership within that particular location to make sure we have English as a second language, skilled base providers and staff readily available to speak with that member. I mentioned medical home, very big. That's been our modus operandi for as long as we've been operating. We have received that designation as well here in Southern California, but that's the model that we've always been following. And then, of course, we have population care managers in our medical office buildings. They are located there with our physicians and our other practice providers, and their entire focus is to be reviewing health of the member by the panel and actively working on populations that need improvement, whether that's diabetes care, and we striate those into several categories, or everything from stop smoking. Those kinds of things have different methodologies and different attachment points to managing that member's care, whether it's something online we're directing them to or it's one-on-one classes, etc. But the whole focus is really around the population and the care that they're needing. And then finally, focusing on prevention needs. I joke that every once in a while we'll get a member who will call us and say, please, please stop calling me. Please stop emailing me. Please. And our comment is, you know, I appreciate that, but we're here to help you thrive. This is our mission. And, you know, I've never really actually said, maybe this isn't the health plan for you. I've kind of more thought it than said it. But at any rate, that's really the impetus for every day's work. And so once we kind of explain it that way and say, we really are here to serve you, I have yet to have someone kind of come back and say, you know, I'm sure maybe some disenroll that I'm not aware of, but at any rate, that's kind of the major focus for us.
Any questions from the audience yet, or should I pitch another one to the team? Yes. Great.
Yeah, I got a microphone for you.
Thank you. My sister's actually a Kaiser patient, and we were talking not too long ago. By the way, she's gotten great care and cured of cancer, and everything's good. But one of my questions is, she had talked to her doctor not so long ago, and they said, you know, what you need to do is you need to exercise 4 times a week. Just 30 minutes, 4 times a week would be great. And I thought about the earlier presentation and the engagement part and the motivation part, and that still seems to be something that's missing because there is no follow-up to see if she's exercising 4 times a week. So how do you see that happening for the future? Because I know we want to get to that point where it's very preventative and very health-oriented versus health care and curing her of cancer. Thank you for that, but the next step.
No. And I think that's something that all of us probably can add to, not just Kaiser, so please start.
Thank you. Exactly. One of the things that we do offer is an app just called Everybody Walk. And our whole focus is, please take your phone. It will give you walking paths. It will track and trend how much you're walking. You can actually we can't load it up to our database yet, but I'm hoping to in the near future. It is more of a partnership. We struggle with that. I think every organization does. We provide a lot of things that are online, in person, a lot of free programs, and things that aren't free. I think that one of our mechanisms that we're focused heavily in is how to relate more to the community, so that we're bringing the community in and the member in with their relationship with the community. Some of our service areas are heavily faith-based, and they are focusing very heavily with relating to the local community and churches and whatnot. Orange County is a very diverse community, and we've not focused on that as much, but I think everyone in the room is saying that's the next component. But we do offer personal health care coaches. There is a personal health care plan. If you go online, it will assess it. It will tell you exactly what you need to be doing, and would you like a personal health care coach? You dial up and you can get someone online right then.
How about the rest of you?
I think that, I think that that's really key, is this question of continuity, and what's the continuity of the relationship that you have. I think that I've just cursed on the mic front. What's the continuity of the relationship that you establish, and how do you make sure that somebody doesn't kind of get dropped? And that, I think, is all of us. There's a lot of challenges in that, because if you have a diverse network and somebody's moving from acute care to ambulatory care or acute to specialty care. So I know that, and I don't want to speak for St. Joseph Health. I know that one of the things they're developing is a transitional care clinic, which is very much about sort of when people are making that transition from hospital to ambulatory, to make sure that that's got a continuity to it. But all of these things are going to co-evolve, and I think what we're very focused on is building the platform and the system that allows that continuity, and also allows somebody like your sister to decide how she wants to track exercise, to connect the way she is exercising, and maybe the way she's exercising is running, or maybe the way she's exercising is just sort of stepping with a Fitbit, and that's kind of an elective thing, but to have that start to be tracked. So I think the challenge, and it's two things working side by side. So obviously, as somebody from a technology company, I'd love to say we have some magic technology that's going to keep somebody connected, but it's the tandem of the physical points of presence and the human being. So we're working on a next iteration of the wellness program within St. Joseph Health as an application of our platform. And what we're finding is where the wellness program works inside of St. Joseph Health for their employees to defer to actually cause things is where they've got on-site primary care wellness centers. And where it doesn't work so well is where they don't, because the personal connection is incredibly important. And they have a lot of digital tools for it, but that personal connection has to be brought along side by side.
Yeah, I think that's exactly right. I mean, we're looking at our communities and the idea of training our churches and our community support, the Rotary Club, et cetera, on how they can be volunteer coaches or volunteer helpers, and having them partner up with people that are smokers or overweight, because it's hard to do this on your own. And I think anybody who's really done anything significant in their life, they didn't do it on their own. And so the more that we can put people together and then measure what they're doing. And so we're talking about things like having community challenges where we get all our communities in the ACOs and see who does the most who does the most miles of walking in a community per capita, et cetera. So we've got some contests and things that we want to do, but we need technology to measure, but we need people to implement.
I think this is one of the key points about this whole question of moving from worrying about the health of the people who show up to see us to worrying about the health of the population, is exactly this fact that 90% of the care doesn't take place under the roof of the hospital or in the context of the clinic. It's self-care or family care. It takes place in the homes, in the communities, and that's why you hear so much conversation today. I mean, I think it's always been there at Kaiser, but it's one of the reasons you hear so much conversation about figuring out how to make this a community project, because that's how we're going to get to those people. And I see we've got a question over here.
Thanks, Jen. That's a really interesting discussion here. And so getting a little bit of an understanding of population health and your patient engagement rates. I'm really kind of curious, Lynn, in particular, since you seem to really adopt more of a community approach for patient engagement, how your engagement rates are compared to other organizations. I guess my first question to the rest of the panel is that obviously you're using communities as one of your strategies for an outreach. How are the other panel members doing this? What are you doing from a community outreach standpoint? And how are your engagement rates compared to perhaps maybe the other two? It's kind of a two-part question.
Well, it's interesting because and I don't know what Kaiser's experience is. And by the way, I'm a Kaiser member, and we've modeled the whole ACO after Kaiser. So I admire that health system, and George Halverson is my personal hero, and why I went into this work. But the literature shows that about 50% of patients that you try to engage into care management programs don't engage. We see about 5% decline. And we find that fascinating. So far, we're only seeing about 5% of patients. But remember, we know all these patients, and so we see them in the grocery store, we see them in the soccer field. A small town is a very personal thing, as I found out as a CIO of a critical access hospital. Everybody knew everything. My first day on the job, I walked in the door, and they said, "Hey, they announced at the Rotary Club this morning you bought a house. Congratulations." I'm like, oh boy. I'm a New York girl. That's a small town.
I think that's a far cry from the sort of insurance approach of the 1980s, where somebody identifies, which is still going on, of course, where somebody identifies you from a report, and a faceless case manager calls you on the phone and says, please call this 800 number back to engage you in a program. We'd like to talk to you about a program. That's a very different thing than having someone talk to you about this, or a personal connection to it.
But a certain amount of it is unknown right now. The old saw in retail was, I know half my money on advertising is wasted, I just don't know which half. Right, and yet now with analytics being applied to retail, they actually do know which half, and they're eradicating it. So I think one of the benefits of digitizing, it's not I think a lot of times we'll get into the question about digital and personal and warmth and human touch, but one of the undeniable benefits of digitizing engagement is the analytics. What is working and what's working for who? Because it is, as Jan said, one size isn't going to fit all. So critical part of a platform design around this, and I'm sure anybody else who's designing a similar platform to ours, is to build in the watching of usage and uptake and dwell time and understanding which things are being picked up on by whom and what impact that has over time. So making sure you build the alongside the system for engagement, that you build the measurement system to be able to report and to be able to adjust strategies.
I think we also have a lot to learn from the consumer marketing area, and I realize every one of us is sort of worries about what that will mean. But if you think about the ways that they have learned to target our behaviors and get us to buy unhealthy stuff, what if we were able to use some of those same means to turn people's behavior in a new direction? And I think that is an untapped area.
You said consumer marketing?
Yes, very much so. And then to piggyback on I think the question was around how much are you really relating to the community? Was that kind of how much are you getting benefit from it?
So you have different approaches
Yeah.
to population.
Yeah.
You can have a nurse practice to somebody who's a diabetic, or
Right.
what have you. And maybe they'll get a relationship going, maybe they won't. But the other hand is you can go out to the churches, you can go out to the Rotary clubs and get them to help work. And so I'd be interested, especially with Kaiser, if you've done maybe you're doing this, if you are doing this, you've done a cohort study, you've done a study that, what kind of effect of community outreach would be in addition to the traditional.
Yes. Thank you. Yes. Yes to many of those things. There are, in Orange County alone, we direct our investments in our communities strategically around health. I'll give you some examples of things that we fund directly. Sometimes we're not getting the research back yet from that, but I think that that really, frankly, is the next focus for us, is that our direct investments in our communities must link up very, very closely to the outcomes we're looking for. So it's coming. One of them would be we provide video, we provide kids games. We were talking earlier about engagement, so there's direct kids games around healthy eating, et cetera. I didn't develop them. I'm sure there's data around that. I just don't have the data here handy with me today. There's a lot of other things that we look at, even in terms of, we just did a pilot directly around diabetes and the folks that were hardest to reach and hardest to change, and found that there was a lot of integrative work going on that worked well in terms of having them come to a group with like-minded people in the room, and then looking at what worked and didn't work. So we have cohorts of that. It just has to get a lot more strengthened in our communities altogether. But one size does not fit all, for sure.
I was just really intrigued by the whole community approach. I think that's very innovative. It's very brilliant. And if you look at it, you know, a lot of employers try to do this by building wellness centers around that. So it's kind of the same concept, but kind of bringing in that.
It's also got a dimension of people are, I think, a little wary of interacting with their employers around their health. So part of the beauty of the community focus is that it's not somebody who holds your livelihood in their hands. I think we've got one more question. I think we can probably maybe eke out certainly this one and maybe one more.
Hi, my name is Mona. Thank you so much. I want to just start by saying your programs are innovative and they're inspiring, so thank you so much for that. I was just curious as to whether or not you incorporate the cultural determinants that have been discussed today into your patient engagement tools, and if that's the case, then how do you actually gather that information, and then how do you actually incorporate it into those technologies and strategies?
Rural America is about 90% white and about 10% Hispanic. I mean, we have a very, very, very homogeneous population, and so that makes it easier for us because we only have to deal with 2 languages. So for our patient engagement tool, we did in 2 languages. But there's the cultural issues of seniors, I think, that are really important to think about. And when I was getting my master's in public health at Cal, I did a study on elderly diabetics that went to a training center, and I sat them down with a computer, and we went through diabetic websites, right? And so I showed them 20 different diabetic websites and asked them, to tell me about their experience with them, to tell me about their access to the internet. They all had access to the internet. Somebody in their family had access to the internet. They knew how to use, they grabbed the mouse from me, and they actually knew what to do. And these were very poor Black elder, and very old patients. And what was interesting was the content was what was wrong. It wasn't that they didn't know how to use the computer. It was the content. So all of that content was talking about, and it started off being very statistical, and the NIH says, and they could care less. The woman looks at you, she says, I just want to know why my pee smells funny. That's the level that, so when we think about patient engagement and the tools that we create, we have really got to get out of our scientific heads, right, and get to the patient level, because what they will relate to is not what's on the internet today. And I think that's our biggest barrier to uptake with different populations, and I'm sure that's true in other cultures as well, is that we haven't got the right message for those patients, and that goes to your comment about consumerism and not understanding our patients.
When we have health games that are as engaging as Angry Birds, that's when we'll start seeing engagement levels change.
Well, I think also some of it is also having so we're integrating social media platforms into, there's a variety of things. One of the main things, just from a technology perspective, is maintaining very active profiles of people. So we sort of build an understanding of preferences, and not in any way making stereotyping, but understanding ways people like to learn, individuals like to learn, individuals are what's succeeding with people. But part of it is also connecting to social, because social is a way of making sure that people connect to people who are like them or in the same boat, or maybe on the same river, if not in the same boat. And it is a way of you could try and, I'm a little skeptical of making health information fun, because that is not necessarily the answer for every person. It is, so, but it could be the answer for some people. But there becomes a limit. So there's two things we're looking at. One is being very open about content integration, so that if somebody has produced fun game-like stuff for pediatric diabetes patients, it can come into the context of care. And the other is social integration. So if there are communities out there for people, that it can come into the context of care. And I think a tricky thing we all face right now is how much of this to build and how much of it to integrate. And if you look outside of healthcare and you look at financial services or you look at retail, you see that much of what you experience on the internet today is not something that each and every one of those companies went and built their own version of. It is an integrated platform that comes together. Sometimes it's very different consumer experience. My head of design came from Scottrade. And at Scottrade, he was putting together a consumer experience that had all the same feeds that E-Trade and everybody else except for Schwab, which does their own work, had, but it was a distinctive Scottrade experience pulling from that. So some of the ways that we get with, we're not smart enough to adapt to every culture, so we're going to have to be flexible enough to adapt to what we can learn from people who have put in the time on other cultures.
I mentioned earlier about the capturing, which you mentioned too, around capturing of data that's both racial and ethnic, and that's been very interesting, not only for healthcare research purposes, but also for cultural planning purposes and relationship purposes in the individual office, in the individual visit, and then of course with our population care groups. We could, using promotoras, are you familiar with promotoras? They are a group of individuals that work with primarily Spanish-speaking communities that are integrated in and are taught basic healthcare skills that they can relate to their local communities on basic teaching. So that's an example of an area where Kaiser Permanente is working with individuals like this to enter into some communities that are particularly aren't able to access our facilities, where we're really wanting to reach them. Remember, the goal is reach them where they need to be. And so that's just a couple of examples. We have a Vietnamese speaking, just because in one of the clinics that we serve, there's a predominant number of primarily Vietnamese speaking individuals, and so we tailor our particular clinic around that. There's a lot more to be done, but I think it all goes back to what information are you collecting, and then how can you utilize that going forward with the individual member.
I think we are at the end of our time. Please join me in thanking our distinguished panel for this.
Let's also thank Jan for her moderation too, please. Okay.